So our next speaker is Dr. Nitin Chaudhary. He's assistant professor in Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ariman Hospital. And his area of interest is pediatric and obstetric anesthesia. And he will be speaking on point of care anticoagulation viscoelastic monitoring. Welcome, Dr. Nitin. Over to you.
A very good evening to everyone. At the outset, I would like to thank Dr. M.D. Kaur ma'am and Dr. Neerja Banerjee ma'am for giving me this opportunity, and I hope I will be able to justify the topic that has been assigned to me, that is point of care anticoagulation viscoelastic monitoring. Point of care tests are bedside tests which do not require trained lab personnel, and the rapid test result, the undue delay in the patient management can be avoided. Viscoelastic test is an ex vivo hemostatic test which analyzes all phases of coagulation from initiation till propagation. It not only assesses the cellular and the plasmatic coagulation factors, but it also takes into consideration the fibrinolytic system of the body. When compared with the conventional clotting tests, viscoelastic tests are performed on whole blood with a rapid turnover. Their usage is associated with less blood product use. They can detect hyperfibrinolysis, and one device not only evaluates the clotting factors but other components of the coagulation cascade like platelets and fibrinogen. Based on the basic principle of the test, the viscoelastic monitoring can be divided into two categories. The rotational clot measurement, where we have thromboelastography, that is TEG, and the rotational thromboelastometry, that is ROTEM, and the harmonic resonant clot measurement, which includes TEG 6S, hemosonic quanta, and sonoclot. The basic principle of thromboelastography, or TEG, is based on shear modulus, which is the property of the clot to resist its deformation. In TEG, a disposable cup is there in which the blood sample is collected. A pin suspends from a torsion wire in the center of the cup. The cup oscillates at fixed interval of 5 seconds, and the clot formation occurs between the pin and the cup wall, which opposes the rotation of the cup, thereby generating the torque forces which then displace the spin. The torque forces which are generated are read by the transducer and are interpreted in a form of a trace. Now this is a TEG trace. There are various components of the TEG trace, and one need to know these definitions so that you can interpret the TEG trace. First we have is the R time. Now the R time is the time taken for the initiation of the fibrin formation. It is taken up to the point of 2 mm amplitude on the TEG trace. Next we have is the K time, which is the time taken for the amplitude to rise from 2 mm to 20 mm. Then we have the alpha angle. Now this alpha angle is the angle which the tangent makes with the horizontal, and this tangent is drawn at the point of 2 mm amplitude. Okay. Then we have the maximum amplitude, which is the maximum vertical height attained by the graph. Next is the LY30, that is the percentage decrease in the amplitude of the graph after 30 minutes of maximum amplitude attainment. And then we have the LY60, that is the percentage decrease in the amplitude after 60 minutes. For interpretation of TEG, one needs to know the clinical implications of these parameters, that is the R, K, alpha, MA, and the lysis 60 and 30. What is the clinical implication of these values? Okay, so you need to know the normal values, only then you can interpret the abnormal values. And the interpretation is equally important. Now the R time indicates the concentration of the coagulation factor. So depending upon the R time, whether it is prolonged, whether it is reduced, you will get to know the status of the coagulation factor in the patient's blood. Next, we have the K time, which is a measurement of the clot kinetics, and it corroborates with the fibrinogen level in the patient's blood. Next is the alpha angle, which is the rapidity of the fibrin buildup and the cross linkage. The maximum amplitude, that is the MA, it corroborates with the platelet abundance or function. And last but not the least is lysis 60, lysis 30, which corroborates with the fibrinolytic system of the body, and it depends upon the plasmin and the plasminogen levels in the blood of the patient. Now thromboelastography has got various assays. Now these various assays are required so that various components of the coagulation cascade can be well studied and well interpreted. Thus in CK we use the reagent kaolin, which helps us to interpret the intrinsic pathway. CKH has got heparinase, which inactivates the heparin which is present in the blood of a heparinized patient. Rapid TEG is used for better interpretation of the extrinsic as well as the intrinsic pathway. Platelet mapping helps us to assess the platelet function, and functional fibrinogen helps us to assess the fibrinogen levels better in a patient's blood sample. Now we come to interpretation of some of the abnormal TEG traces. Above here we have a normal TEG trace and below is the abnormal. So when you compare the two, we see that the R time is prolonged, the K time is prolonged, the alpha angle is decreased. So most likely it is a case of anticoagulation factor deficiency as the R time is significantly prolonged. Now this is a next abnormal TEG trace where we have that the maximum amplitude is decreased. Okay, so when we talked about the interpretation of maximum amplitude, I talked that it is to do with the platelet function as well as abundance. So most likely it is a case of platelet dysfunction. Next we have is an abnormal graph where the lysis time is significantly increased. So there is too much of fibrinolysis, right? So it is a case of fibrinolysis. Now this is the last abnormal TEG trace. Now what you see here is that the R time is decreased, the K is decreased, and the alpha angle is increased, and the maximum amplitude is increased. Now when the R is decreased, that means the fibrin formation initiation is very quick. Again, the amplitude is increased, the alpha angle is increased, so there is a rapidity of fibrin formation, right? So everything is increased more or less. So it is a case of hypercoagulable state. Coming to the treatment-based approach to TEG. Now for treatment-based approach, you need to ask three questions. Firstly, how fast? This would depend upon the R time. Okay, so if your R time is prolonged, that means you have coagulation factor deficiency, which can be corrected giving fresh frozen plasma or the prothrombin complex concentrate. Next would be if this is fine, if your R time is fine, the next question you need to ask is how strong. So you have to check for your maximum amplitude. If it is weak, then you have to check what is the deficiency, whether it is the fibrinogen or the platelet. So for that, you can run two assays as we previously talked about, functional fibrinogen or the platelet mapping. And accordingly, we can give cryoprecipitate if there is a deficiency of fibrinogen, or platelets if the platelets are in a lower number. And last but not the least will be lysis. So if the lysis is too high, that means the fibrinolysis is happening in this patient. So you need to give something that is an antifibrinolytic agent. So the drug of choice in such case will be your tranexamic acid. Next, we have the basic principle of rotational thromboelastogram or ROTEM. Now, this is completely opposite of what we had in TEG. In TEG, the cup was oscillating and the pin was stationary. However, in ROTEM, the cup is stationary and the pin oscillates. Onto this pin is a mirror. Light falls on this mirror and the reflected light is then taken up by the photodetector and is processed. Now when a clot forms, the spin oscillation will diminish and there will be a resultant decrease in the light reflectance which is captured by the photodetector, and this changes will be then processed and we will have a ROTEM trace. Now this is the ROTEM trace. Now the ROTEM trace looks very similar to what we have in TEG. However, there is a change in the various nomenclatures. Now what was defined as the R time in TEG is now called as the clotting time in ROTEM. The alpha angle remains the same. The K time of TEG is interpreted as the clot formation time in ROTEM. The MA or the maximum amplitude is read as the maximum clot firmness in case of ROTEM. The lysis 30 remains the same as that in TEG. The interpretation will be exactly the same. Yes, the value of these timings will change, so you need to remember them, and they will also change with respect to the assay you are doing. Okay, the assays we'll be subsequently talking about. As in TEG, similarly in ROTEM also we have various assays which help us to analyze or assess the various components of the coagulation cascade. The names are namely the INTEM, HEPTEM, EXTEM, EPTEM and FEPTEM. As the name suggests, INTEM, so it interprets the intrinsic pathway. HEPTEM, so it has got heparinase in it, so it can be used for assessing the blood formation in heparinized patient's blood. EXTEM will assess the extrinsic pathway. FEPTEM will be used for testing the fibrin. Now coming to the treatment-based approach for ROTM, it remains exactly the same way as we did in TEG. In TEG, we asked three questions: how fast, how strong, and subsequently how long. But the only difference between TEG and ROTM will be your nomenclature. So you need to be very thorough with your nomenclature. For how fast, we will be seeing here the clotting time. In ROTM, if the clotting time is prolonged, then you have to give FFPs and prothrombin complex to this patient. If CT time is normal, then next would be your clot firmness. How is the maximum clot firmness? If it is weak, then you have to see whether there is a deficiency of fibrinogen or platelets using the various assays, that is the FIBTIM and the ROTM platelet, and accordingly you will transfuse cryoprecipitate if there is a deficiency of fibrinogen or platelets in deficiency of platelets. And last but not the least will be how long. So you will be seeing your lysis 30. Now if lysis 30 is high, that means you have to go for a anti-fibrinolytic agent in the form of tranexamic acid. Now coming to the role of viscoelastic tests, which are increasing leaps and bounds with a newer addition every other day. Now their role in massive bleeding and trauma patients. The European guideline as well as the American Society of Surgeons recommend the use of viscoelastic test not only to assess and monitor the hemostasis but also for regulating the blood transfusion in the traumatic coagulopathy. The role of TEG and ROTM in cardiac surgeries is well known, and NICE diagnostic guidelines also recommend the use of ROTM and TEG for detection, management, and monitoring the hemostasis not only intraoperatively but also in the postoperative period. The role of TEG and ROTM in obstetric cases, that is in the postpartum hemorrhage, is very sparse. However, in case you have the availability of these tests, one may use them. In cases of liver transplant, now a patient with liver transplant can present with a varied clinical features. It may present as massive bleeding, or they may present in a procoagulant or a fibrinolytic shutdown. So these viscoelastic monitoring will help us to balance between the lysis and the hemostasis so that the blood transfusions can be done as per the requirement of the patient and undue transfusions can be avoided. TEG and ROTM can be of benefit in sepsis and septic shock, where one may have clinical picture ranging from an increased bleeding tendency to a hypercoagulable state. And with the help of TEG and ROTM, one may avoid unnecessary blood transfusion in these patients because the blood transfusion have their own complications. Now, lysis index could be a more reliable marker of severe sepsis. In liver disease also, the patient may present with either bleeding tendency or in a prothrombotic state. So if you have the availability of TEG and ROTM, you may avoid over-aggressive platelet or the PTINA correction in these subset of patients. Now, COVID-19 is a hypercoagulable state with an increased risk of thrombotic complications. So TEG and ROTM will help us to assess the hypercoagulable state in these patients so that the medical management can be done at the earliest, and they have been shown to predict the thrombotic complications as well. Now, last but not the least, we have the emerging indications, namely guiding the antiplatelet and the anticoagulant therapy, and for improving the diagnosis, prevention, as well as the treatment of venous thromboembolism. Coming to the limitations of TEG and ROTM, being an in vitro test, it cannot reflect the contribution of the endothelium to coagulation. They tend to be insensitive to aspirin and clopidogrel. The sensitivity as well as the specificity may vary in different populations, and these device needs daily calibration. It has been found that preoperative baseline TEG and ROTM are poor predictors of postoperative bleeding. TEG and ROTM do not reflect the effect of hypo or hypothermia because these measurements are done at a temperature of 37 degrees, which is the body temperature. So they do not reflect the change of hypo or hypothermia on the blood parameters, on the coagulation parameters. It cannot detect coagulopathies caused by abnormalities in the physiological conditions like abnormal pH or the calcium ion concentration. And last but not the least, these tracings are not interchangeable. So if a patient was initially monitored using TEG, it is required that subsequently he be monitored or she be monitored on TEG and not to be switched over between TEG and ROTM as per the convenience. Last but not the least, we have the basic principle of sonoclot. A word about sonoclot. So the basic principle is the harmonic resonant clot. Now in SonoClot, we have a hollow open-ended plastic tube which is mounted on an ultrasonic transducer. Now this transducer generates vibration at a frequency of 200 Hz. Now as the clot is formed, there will be an impedance to the vibration, and this impedance is then traced by a transducer. So this is a SonoClot trace. It definitely looks very different than your Rotem and TEG, so you need to keep in mind, and the nomenclature of the various time frames would be different. So we'll be subsequently talking about it. Coming to the interpretation of SonoClot, for clot initiation we have the activated clotting time, that is the ACT, which is equivalent to the R time of TEG. Then we have clot kinetics, where we have the clot rate, which is equivalent to the K time of TEG. And for clot strengthening, we have the peak amplitude or the peak, which is equivalent to the maximum amplitude in terms of TEG. The interpretation will remain the same. So with this, I come to the end of my presentation. I thank you all for your patient listening. I will be more than happy to answer your queries. In case some of the queries still don't get answered because of the short time that we have, I'll be more than happy. You can mail it to them on my email ID, drnitinchaudhary@yahoo.in. Thank you so much.
Thank you so much, Dr. Nitin, for such a wonderful presentation. There are no questions in the chat box, as I can see.